Hello and welcome everyone. Thank you again for joining today's conversation about reopening after COVID-19 closures. This training is presented by Switchboard, a one-stop resource hub for refugee service providers in the United States. My name is Jason Crislip and I'm the Director for Training and Instructional Design, and I oversee the Switchboard program. I'm joined today by a panel of distinguished guests that I will introduce shortly. In addition to our guest panelists, I wanted to mention that representatives from ORR and PRM are also in attendance today, and they may be assisting with questions that arise through the chat box and or by following up with some additional information, either through Switchboard follow-up communications or through other established channels. Today's conversation will run for about 1 hour and it is being recorded. The recording will be posted on our Switchboard website, and you will be emailed a link to the recording in about 24 hours. The webinar transcript will also be posted on our site in the following few days. Please feel free to share this resource with colleagues who may be interested but were unable to join us today. Let's take a quick look at some logistics in Zoom if you haven't used it before. All attendees are currently muted and you will remain muted throughout this webinar. Note that you can switch between phone and computer audio at any time under the audio settings menu in the lower left of your screen. As we hope to host a lively conversation on this very important and timely topic, we absolutely welcome your comments and questions throughout today's session. You can click the chat bubble icon in the bottom center of your screen to open a chat. You can then select your audience for your chat message through a drop-down menu. If you'd like for everyone to see, please select all panelists and attendees and everyone will be able to view your message. Please use this chat function for general comments or to express technical issues, things of that nature. For questions, today we're going to use the Q&A function. You can see that button down there at the bottom of your screen. If you see that someone else has submitted a question through there that you also feel you would like answered, please upvote it by clicking the thumbs up icon next to the question. We'll do our best to field as many questions as possible that you pose at today's session. We're also going to try to address many of the questions that you all submitted when you registered for the webinar. The learning objective for today's webinar is pretty straightforward. We hope that by the end of today's discussion, you will be able to name at least one promising practice or useful resource to inform the development or implementation of your reopening strategy. And before I introduce our panelists, I wanted to note that the speakers will share their recommendations based on their current knowledge and context, but bear in mind that information about COVID-19 and regional circumstances vary and are changing rapidly. The views expressed by the panelists today are based on their individual professional experiences and do not necessarily represent the official position of the Office of Refugee Resettlement, the Centers for Disease Control and Prevention, or the U.S. Department of Health and Human Services. And with that, I'm very pleased to introduce our guests. Emily Jentes is currently the team lead for the domestic program with the Immigrant, Refugee, and Migrant Health Branch at the Centers for Disease Control and Prevention. Michael Kacka is a medical consultant with the South Carolina Department of Health and Environmental Control, where he serves as the South Carolina State Refugee Health Coordinator. We're joined by Sarah Peterson, the State Refugee Coordinator and Chief of Office for Refugee and Immigrant Assistance for Washington State. And Sarah also currently serves as the president of the State Coordinators of Refugee Resettlement Board. Tracy Reines is the Regional Director for the Atlantic and Central Region at the International Rescue Committee. And Kim Skrobarcek is a medical officer with the CDC. And so we've reviewed and consolidated all the great questions that we received from everyone via your registration forms. And so we'll begin with some of those questions. But please remember at any time you may add questions or request additional clarity using that Q&A function. So I'd like to begin with some questions around the theme of new arrivals, how we're welcoming new refugee arrivals. The first question, how are resettlement agencies managing the 14-day quarantine period for new arrivals? And I'm going to ask that of Tracy.
Thanks, Jason. So I think the reality of some of the basic logistics around pickups, apartment setups, communication, getting money in people's hands, as I said, apartment setups, I think, and then communicating and staying in touch with new arrivals is not so complicated conceptually, to be honest with you. I think that the logistics involved can be something that really takes planning and intentionality with agencies and with engaging with clients. There aren't that many clients, so the process associated with it is sort of being built as it's going on, right? So offices aren't doing this very frequently. They're few and far between. And so combining the new way of working, us working remotely, communicating with each other, figuring out different process steps like seeing an apartment and getting it set up, like how do we get money to people when we aren't in the office to cut checks. If we have rules about our distancing from each other and clients, how do we get clients transported, right? Are we picking them up? Are we working with Uber? So I think that, to be honest with you, the infrequency of people coming, us getting our own systems in place, as well as just the reality of each and every one of those steps is a new kind of internal process. And that has nothing to do with staying in touch and keeping informed and maintaining connection with clients. So the point is that it is doable, it's possible, it just takes more time and more thinking through, because so many of the pieces that we have in place normally are different now, right? I mean, just the way that we go to the grocery store is different. So doing that on behalf of someone or with someone is different as well. So I would just say, as a little bit of guidance, that we are very clear what our safety norms and protocols and distancing are as staff. So everyone knows those. And as each office and as each group is looking to work with the family on their arrival, on their getting set up, on the administrative pieces associated and communicating, I would just say you really need to think through each and every step associated with it. And as a couple of examples, we've switched completely to, ATM bank cards rather than cutting checks for people. We have switched completely to working with Uber and Lyft to provide transportation to folks rather than us doing the pickups ourselves. We have really clear guidelines around social distancing when we are working with clients directly, that we all know, and we have used other ways to communicate, be it text or telephonic engagement with clients when we need to as well. And the last thing I'll just say is that it takes more time and planning than you might anticipate. So for folks doing that, please keep in mind and really think it through, and like step by step by step by step by step, because it's easy to get tripped up on some things that were normal practice before, but are not now. So there's a quick answer for you. Thanks, Jason.
Thanks, Tracy. Any other panelists want to add anything to the managing the 14-day quarantine period for new arrivals? Okay.
I can add.
Please.
So this is Emily from CDC. I just wanted to point out, so it's, I really appreciate all the amazing work that the resettlement agencies are doing in order to coordinate this, and it's learning new processes and getting everything organized. From the CDC's perspective, and I think when we use the words isolation and quarantine, it's a little, I think, confusing versus, staying at home. And the one thing I do want to emphasize is, we do have isolation, which means that we're keeping somebody who's actually sick away from others. A quarantine is keeping someone who is in close contact with a case away from others. For these refugees and SIVs that are coming in, we don't know their risk. And so we wouldn't call this an official quarantine per se. We do have the recommendation, and we did provide that in April, I think, after I think it was actually at the end of March, beginning of April, that we would recommend that refugees do have a stay-at-home period after they arrive. And I think that, that is talking about all the coordination that is included in what Tracy mentioned. But I do think that this is a time for the refugee to stay home, monitor their health, practice that social distancing. And we're calling it stay at home because it is a recommendation. It's not a requirement. If, you know, they run out of diapers, you know, it's something that, that they are able to go get diapers. But it's a recommendation, not a requirement. But we do think that this time is a time for refugees to be able to practice that social distancing. We don't know the risks from traveling. And so practicing that social distancing for that 2-week period, you know, wearing that cloth face covering, making sure they're staying 6 feet away when they can, 2 meters, washing hands frequently. And, you know, that's also a time for the resettlement agencies as well as the refugees to learn how they would access care if they needed to during that time. And certainly the resettlement agencies, the state refugee health coordinators are all coordinating in that regard. And so I just want to add that just because I think that it is a crucial time. It's a difficult time. It's a time of transition for the refugees. And we certainly want, you know, the refugees to be able to begin with the information they're going to need, especially with COVID in the United States right now. Kim, do you have anything else to add?
Oh, no, I think you covered it.
Thank you.
Okay, great. Thank you, Emily. Moving on in the same theme of new arrivals, there's a question around testing. So I think this also perhaps is best fielded by Emily and Kim. Do new arrivals take a COVID-19 test overseas before travel clearance, or do they receive one in the US during domestic medical screening?
Coming off mute. Great question. And I know that this is on the minds of everyone here. So right now, let me actually just pull up our, I had this up just a second ago. Give me one moment. So in the United States, or sorry, overseas, testing is not universal at this time. And that's partly due to the not having available tests in every place that we're resettling from. And so at this point, right now, what we're working with IOM is to be able to, at the pre-embarkation checks for refugees, look for signs and symptoms of COVID, look and ask for close contacts of COVID cases. And if any of those are found, whether if they do show signs or symptoms of COVID, or they make the case definition for COVID, or they are a close contact of somebody who did have COVID, then they would not be cleared to travel until they had completed CDC's recommended isolation or quarantine period, whichever applies, and then be reassessed. So in those cases where there is, the refugee has been determined to not be fit for travel, there would be a test done if it is available. Otherwise, the time period to wait until that recommended time period would be over. So for somebody who is a case, for example, is a contact, they would have to not have contact with anybody with COVID for 14 days. So, you know, as testing becomes more widely available, new guidance will likely be issued. But at this point, overseas, it's not routinely done. And I would just add to that in the United States, unless the person is actually showing signs or symptoms, depending on the local and the state availability of testing as well, that would be when these tests are done. They wouldn't be routinely done during the domestic screening exam unless the refugee was showing signs or symptoms of COVID. Kim, do you want to add anything to that?
Yeah, and I'll just say that just because the program itself doesn't require screening overseas doesn't mean that it's not going to happen. There are, airlines have their own rules and regulations, and that can vary a lot. And some airlines are requiring testing 72 hours before the plane flight, you have to show either you have to show a negative test result, or they do testing for you, and then there's other airlines that have no such regulations. And then also, different airports may have screening, temperature screening in airports. And so there may be, you may have to deal with positive tests, even if they are not part of the screening process. And it may not be explicitly said on CDC's website, where it says if you have a positive test, don't travel, but we do have parts of the website that do talk about what to do if you are sick. And that would be, if you are symptomatic, and inherently also if you have a positive COVID test, that you shouldn't travel, you shouldn't be using public transportation, and air travel would kind of fall under that public transportation.
Great.
Yeah, but for our refugees, I mean, that mainly falls for our SIVs, but for our refugees, they travel with IOM and would fall under the guidance that I mentioned previously.
Sorry, yes, and I work on the overseas immigrant team, so there's different processes for immigrants that are coming over. So Emily is the refugee expert.
Gotcha. Thanks both. We are monitoring the chat and QA box, so continue to send those questions in. Related in the same area, something we can ask now, and I imagine Michael might be the best person to answer this one. The question is, how are agencies managing refugee health screenings in cases where clinics or hospitals may not be accepting in-person appointments?
It's going to be hard for me to say in general. It's going to depend really highly on the local circumstances of being able to schedule these appointments. I know that we've had a little bit of trouble specifically getting some of the paperwork for the green card applications, the adjustment of status applications done, and we've had to kind of advise how best to approach it. There is guidance out there for outpatient clinics who are going to be seeing patients during this pandemic about how they can approach it. Everything comes down to making sure that you're maintaining that appropriate social distancing, you're getting the message about the mask out there, you're ensuring that the good hand hygiene is happening. So kind of setting up the circumstances, communicating ahead of time to make sure that it's being done safely. I know that there's kind of a challenge of getting these appointments set given the circumstances of what's going on. So really kind of establishing the alternatives on how this can get done, in the current situation that we're facing within the time frame that is available. So just some of the considerations around that.
Okay. Thanks, Michael. I want to move on to a different sort of thematic area around outreach to clients, which of course is also challenging during this time. And the question is, can you share any examples of creative ways to educate clients about COVID-19, in particular, those who may be distrusting of government or public health authorities? And I believe, Sarah, you had some examples you wanted to share.
Yes, thank you so much, Jason, and thank you to Switchboard for hosting this panel and inviting a state refugee coordinator to participate. We've been hearing from across the country and in Washington specific, several great best practices for doing our best to reach out to different cultures and different communities. And I think that we can all acknowledge that behavior change as it relates to public health is a challenging feat for all communities, foreign-born and US-born alike. I think that there are certain specific challenges that are different for refugees and immigrants. And a couple examples of some great practices that we have seen is first, making a concentrated or specific investment in doing outreach to ethnic communities. So The Washington Department of Health invested about $500,000 into contracts with ethnic and community-based organizations to do just that, to make sure that we were targeting our outreach and really helping to deliver a message that people could hear. I think the second thing that many of those on the call are probably already considering and already doing is thinking about who is the trusted messenger. And so really packaging the information and communicating it in a way that people can hear it best. And so for some communities, that's having a religious or faith-based community leader deliver that message. In others, it might be doing it within their own language on a platform, like social media like Facebook Live or WhatsApp, and delivering that message that way. I think the other way that we have really been seeing great success is kind of the third way, which is ethnic specific health boards. And so here in Washington, for example, we have the Somali Health Board that has done a really great job of trying to make sure that messages are targeted and specific for their community. So those are just three great examples that we've seen across the country.
Great, thank you. I think, Emily, you had a few examples you could share as well.
Yeah, very similar to what Sarah mentioned. I think that when we've heard about different innovative ways that people have been communicating with our refugee populations across the country, the key themes seem to be video and audio messaging in short snippets that can be shared via WhatsApp. That Facebook Live with community leaders seems to be very, very effective, as well as doing PSAs with people who have actually gone through coronavirus, signs, symptoms in the virus, with in providing some of the example, working with the health department, having that person work with the health department on key messages, and then actually giving that out as a PSA on the radio. And so it's been some of the same themes that Sarah has mentioned is really, that's part of the struggle that it's been, at least from the CDC's perspective, is that there's no one size fits all solution. Each community is a little bit different, and each community's network is a little bit different. And so customizing those responses and needs with each of the communities, I think, has been most successful. And it's really been about having the community speak back with the community rather than having the governmental agencies come in. It's really about providing that close and trusted interaction.
Great, thanks for that. Some really creative ideas in there for people. And on that same theme on outreach to clients, another question came up. With the rapidly changing environment, how can refugee service providers effectively communicate about these changes to clients? And I think this one will start with Tracy and see if others can add to it.
Yeah, I think like any kinds of, communication and things like this is consistent. More consistent, the more the better. So the messaging in terms of, hygiene, hand hygiene, safe distance, everything, and pieces are pretty consistent, to be honest with you. So the content isn't as, in some ways it feels dynamic, but it's actually really consistent content messaging to be aware of. I think that I don't like to always say that every problem is an opportunity, but I do think that in this case, in terms of the way that we engage with clients, different platforms, SMS, we're piloting a text it program to try to get more information to clients in a variety of different platforms. When we do start reopening offices, we do have our messaging translated to 10 different languages. We have an animation that helps to explain content about behavior and kind of basic etiquette and hygiene information. And I think really just taking advantage again of the networks that we have and the broader platforms by which we communicate. But I'll just say briefly You want to keep it simple. You want to keep consistent messaging in terms of what individuals can do and in their immediate environment, what they can do, and have platforms by which those messages are delivered in a variety of ways, not just in person. So whether it's texting, whether it's incorporated into our client conversations under other programming areas, as well as if and when we start opening up or when we start opening offices, having those messages be accessible to a wide range of audiences as well.
Thanks, Tracy. Your signal's a little bit in and out there, so maybe if you turn your video off, there might be clearer audio. Is there anyone else that wants to add to this question on communicating changes effectively to clients?
So this is Sarah, and one of the things that I would add for all of the participants on today's call is that there are plenty of resources that have been created, and the CDC has done an amazing job, and Switchboard and Washington State actually created a directory of all of the different messages that are available and that are available in different and been translated in different languages. Partners across the country have done an amazing job of really trying to collaborate and come together. And so if you're looking for a specific audio message in a specific language, before recreating something, it might already exist. And I think that we can make sure to get those resources out to everyone. And then I think just making, the only other thing that I think Tracy did a great job of covering everything. A lot of it's that in-person connection. So we know that we've heard from a number of the refugee resettlement agencies in Washington that they have been doing individual outreach to the refugees that they've resettled over the past 5 years and beyond to just connect with people. And it's similar to like the texting or just having a phone call and making sure that people are doing okay. I think that individual approach, if you have capacity, is really able to customize it like Emily was talking about and can really help to reach people with a trusted message.
Great. Thank you for that, Sarah. And I'll call everybody's attention to the chat box. We just dropped in a couple resources on outreach, an upcoming webinar, and then just some guidance for you. So please check that if you're interested. And then we'll move on to sort of another overarching theme on planning and risk analysis. And these are kind of heavy questions. And again, there's not going to be one-size-fits-all answers, but certainly something we can explore together. And the first question is, what frameworks can we use when conducting a risk-benefits analysis about reopening? For example, risks of clients contracting COVID-19, or risks posed by clients' reduced access to needed services. And not to put you on the spot again, Tracy, but I thought we could maybe start with you.
Sure. So the framework, or sort of the parameters that we use, sort of starts from the very top and go down. I'll try to do it quickly. But clearly, as an organization, we are looking towards CDC and sort of national level guidance, right, around the epidemiological issues, around testing, around new cases, around access to health services. So we've so underneath this umbrella of the broad conversations and following what is happening nationwide and locally around the virus. Within that, our organization has very strong parameters on what our triggers are for reopening. And if those two sets of guidance, right, local guidance from the sort of governor or mayor, is at odds with our organization's guidance, we take the more conservative approach. So whichever one has the more conservative and cautious triggers for reopening our offices, that's the piece we take. So that's the first question of what's the local or national and local, and more importantly, local guidance, and then what is our organizational guidance within that, and which one is going to lead in terms of when we can start to think about reopening. Underneath that, we as an organization put together parameters that had sort of 6 areas to think about in terms of safely reopening, and that's having pieces in place for hand hygiene, source containment, meaning if you're sick, you can't come to work, office cleaning, environmental measures, physical distancing within offices, access control, meaning making sure people coming in are not sick, use of masks, and then trainings, right? So we have these 7 pieces. Within that, each office has to develop specific protocols by which they can implement and make sure that we've addressed these issues. So that's sort of like the reopening kind of guidance. The question of, if all of that, then what other considerations are there that are localized and that have to do with clients? And I think those are things like, you know, how many arrivals are you expecting per office? What are partner organizations doing? What's happening with schools? How effectively have you been able to deliver services remotely? What is the, you know, how are people getting to your office? So I don't want to throw everything at the wall, but the point is that there are some clear structures that are based on science and based on health data, and based on sort of localized external and internal guidance about how to have a safe environment. But then there's a set of questions that are going to be office specific that you basically just, I wouldn't say have to weigh, because I know that's the question, but that factor in to give a more complete picture that do vary by location. You know, it is very different being in New York City, taking the subway to get anywhere than it is, let's say, for example, Wichita, Kansas, where you're driving or people are riding bikes because they're close to the office. So they're very different realities locally that have to be taken in. But I think that the main point is that you want to have each organization have a very clear set of parameters that are based on science and evidence that you can even start thinking about opening and providing services. The last thing I'll say on that is that we have, all services are not created equal, right, in terms of how they are delivered. So we do have some areas like immigration, for example, where it is necessary to have in-person contact for document signing, for time-sensitive issues. And we have figured out ways in some offices that are ready to open or start opening that it's by appointment. It is, you know, very limited on the number of people in the office. It's very clear what people are there for and not there for. The timing is kept tight. So there are some services that do need in-person engagement, and we're aware of those, and we're separating those out from others that might be able to continue to benefit from remote service provision. And again, I just hope that at the end of this, you know, that we have as a network collectively within the resettlement agency universe have figured out ways to provide services in a more dynamic and a wider set of options than the typical model of sort of coming into our office to provide a service, right? So again, not everything is always an opportunity, but I do think that hopefully at the end of this, that we do just have a wider range of possibilities and familiarity and infrastructure and experience by which to provide services in different models. So hoping that comes of this in the end, and it's pushing us that direction. Thanks.
Great, thanks, Tracy. Any other panelists have anything to add for this question?
Sure, I'm happy to jump in on this one because I serve part-time as the South Carolina State Refugee Health Coordinator. My full-time position is I'm a medical consultant in infectious disease control for the South Carolina Department of Health and Environmental Control. So, you know, I'm involved with helping to write these guidelines at the state level. And one of the successful approaches that I found is when we have to allow for something, I start with putting it in the absolute strictest possible terms that will absolutely lock down any possible transmission of the virus. And then I take it from there and look at the unacceptable consequences that come out of that approach and say, okay, we need to address this thing. How can we do that? How can we do it in the safest possible manner, knowing that now we're opening up a little more risk for transmission, but it's still an unacceptable consequence. We have to address it, and kind of working down the line from there. So that's how we kind of balance this risk benefit with any of these new guidelines that we have to kind of put together. And that's the that's the approach that's kind of helped me keep my sanity with these kind of tasks that involve writing very difficult guidelines and in a lot of uncertainty. So maybe that will help some people as well.
Thanks, Michael. I appreciate that insight. And before other, before other panelists weigh in, I'm going to introduce the next question because I think it's a similar question about balance. And this question is, how can we best balance shifting energy and resources towards improving virtual services versus implementing safety measures for in-person services? So again, this is sort of about balance. We have to continue to work in the meantime, but how do we still focus on what's coming? And I think maybe we can start with Sarah on this one, and again, invite other panelists to.
Thank you, Jason. As I was thinking about this, I was thinking about a famous quote from that Winston Churchill is credited as saying when he was working to form the United Nations after World War II. And he said, never let a good crisis go to waste. And so it's similar to what Tracy's talking about, taking advantage of the opportunity that we've been given to address a lot of different inequities that I think have been inherent in our communities and our systems for a long time. And as we think about, this kind of question, we have kind of three guiding principles, which, the first one is obviously make sure employee and customer safety comes first. So as we think about, are we going to focus on, remote or in person, how can we make sure that whatever we're choosing, it's safety first. Also using the best public health and safety practices, which I think Tracy talked a lot about, and just focusing on helping people get access to personal protective equipment if they are choosing to meet in person, and as well as cleaning supplies. And then also, I think we're committed to providing timely and equitable public service, right? And I think that's all, those are the three guiding principles that we're all really trying to look for in that balance. And I think one of the things that we've really learned during this crisis is that there are a lot of services that we have historically provided in person that are prime candidates to provide remotely. And so thinking more creatively about how do we do that. So if you are still working on helping people apply for a job, I think that there are some things that we can do to work with our clients and the people we serve to help navigate that process. I think as we go through that, one question that we find ourselves asking is, where are the service gaps and where are the inequities? And one of the big inequities that we've seen with our refugee and immigrant communities is the digital divide. So not only the access to technology and the access to fast internet, but also the ability to understand how to utilize the different technology which is needed to effectively access services. So a lot of healthcare providers, for example, are going to telehealth appointments. That's an amazing opportunity, a really great way to connect, but sometimes that requires a case manager or a navigator to help people learn how to even connect to Zoom and how that works. So I think part of the balance is, identifying the service gaps and figuring out where do we have to provide in-person services and where can we really start making sure that we're shifting and keeping and retaining capacity to do remote learning. Obviously, I think one of the things that's the underlying assumption in our conversation today is that we have no idea how long COVID-19 will be with us. And so being prepared to do both in a safe way is our obligation. And as a state refugee coordinator, and our office's goal is to really support those ethnic community-based organizations, the refugee resettlement agencies, the community colleges that are trying so hard to provide a broad array of services to folks, really provide them the support and flexibility to do that effectively. So I'll pause there for anyone to see if anybody else wants to add anything.
Thanks, Sarah. That's such a beautiful segue into the next question. Maybe I'll move into that quickly, and then, because it's all part of the same conversation, sort of building on those lessons learned, what are state agencies and resettlement agencies, how are they building flexibility into the reopening plans to accommodate future spikes or resurgences of COVID-19 or other emergency situations that may arise? And maybe we can start this time with Tracy and perhaps back to Sarah and others. So Tracy, go ahead.
Yeah, sure. You know, we did an evaluation of our reopening for one of our offices overseas, and one of the main takeaways from that was communication. Like, let people know what's happening, what you think, what you're thinking, what the ideas for reopening or not are, early and often, because I think that most people understand that this is an environment that is changing, and it's very clear in the last few weeks how this might spike up and down in a real way. So I would just, for one thing, just say out loud to everyone, communicate. But in that communication, we have said with our guys, be prepared to be flexible and be prepared to be, I would say be prepared to be flexible. I think my audio is not great, so I'm not going to talk too much more, but I will just say build in flexibility to your plans and have folks understand the implications of opening prematurely for when you might need to shift gears and close down again. And I'll address my audio as well. So thanks.
Okay, thanks, Tracy. I think we caught most of that, but yeah, if you can get that sorted. And then maybe back over to Sarah for those insights, and then perhaps others.
Yeah. One of the things that I think has been so inspiring during this challenging time is the flexibility that many of our local providers have implemented to meet the needs of their communities. And I think that we have heard from all of our providers some amazing best practices from the work that they've been doing and just trying to respond to that need. For example, one of our resettlement agencies shared that they have always remained open for the duration to best meet the needs of their staff. Some staff may not live in a house that is suitable to teleworking. And I think, as Tracy talked about, really being very local and specific around what are the needs of our staff in order for them to be able to do their best job, and then how are we may need to continue to do some in-person programming, and how can we do that in a safe fashion. So I have been really inspired also by community collaboration. We have heard from a number of providers who perhaps have historically wanted to collaborate with another group, but haven't always had the time or the means, but have really rallied around helping communities. I think of food drives as one example where people have, I've said, well, there is this food and we really need to get it out to our community. And so they, deliver 800 boxes of food as a collaborative together to respond to community need. I also think of local communities I've seen across the state of Washington, and I've heard of other initiatives across the country where local communities are investing resources to help folks. So whether that's a cash assistance program or resources to do that community outreach, I think that paying attention to what's happening on the local level is also really helps to provide greater flexibility as we need to be able to effectively and quickly respond to this disease and pandemic.
Great, thank you, Sarah. Anyone else want to weigh in on this one before we move on? We're going to shift gears a little bit and focus on the theme of health and safety measures. And I think we'll be relying on our medical professional panelists between Emily and Kimberly and Michael for these next few questions. The first question, what safety guidance should organizations provide to staff for going into the field in the course of their work, such as client home visits or donation pickups? Maybe Emily or Kimberly, if you could start us off on this one.
Sure. So I'm really glad this question got asked. And I wanted to just talk a little bit about the ways that we at CDC have been trying to fill some of the gaps in the communication. So initially, I think, some of the other panelists and have talked about the initial translations that we were able to get through, and I think those were really helpful. And also on the theme of communicate, partners at IOM, PRM, ORR, and CORE, we've all been meeting regularly to talk about where there's still gaps in communication with the continuity of care, starting from when the refugees are overseas all the way domestically, and then to your situation as resettlement agencies. And so I just want to talk briefly about those steps in the process, and then talk about the different resources we have developed or are developing in that regard. So the two themes that I want to get through are that we're trying to work on continuity of messages. So making sure that there's such an influx of information that are given to refugees along the way, that how can we reinforce the same messages over and over again? So overseas, we're, in addition to the materials that are already provided by CORE, IOM, and CDC, we worked on developing a one-pager talking about those at increased risk for COVID-19 and what they need to be doing before, during, and after travel. So that's in development right now. When they get here to the port of entry, we've also been working with our partners at IOM and PRM, ORR, and CORE to develop a care booklet. So this would be given at the port of entry by IOM to the refugees. And it would talk about this initial resettlement period, this initial 2 weeks, and what to do during that period. And so it talks about those key prevention messages of preventing, washing hands, wearing the face covering, staying 6 feet away during that 14 days, trying to stay home as much as possible. But then also talking about monitoring yourself for signs and symptoms and having a thermometer. IOM is going to be able to provide thermometers starting in August, and how to take a temperature, how to clean the thermometer for the rest of the family. And so that care booklet initially providing that those key messages during that initial resettlement time. And then I think for you all, what we've been working on are what are the key interactions that you will have with, and I really wanted to have it done by today, so I apologize, but it will be coming your ways so hopefully soon. What are those key times of interaction that you connect with your refugees? And what are the CDC guidance documents that apply to each of those situations? So pickups at the airport, or home visits, or going to the Social Security office. What are those key time periods? And because CDC, I think everybody's a little bit on information and guidance overload. What are the key documents that you all at the resettlement agencies could pull together for that time frame or that interaction to know what the guidance is for those particular situations? So we are working on that as well. And specifically for this client home visit, this is we have plenty of guidance on CDC's website about what happens in a healthcare setting. But this is a gap that we also recognize, that for people coming into homes, whether it's social workers, whether it's physical therapists, whether it's resettlement agency workers doing home visits, there needs to be some guidance on what to do during that time and what the home visit and how the refugee would prepare, as well as how the case workers would prepare. So we are working on that guidance as well. But I think when it comes down to it, the key messages for COVID, I think we could all, say them in unison, are the face coverings, washing hands frequently, trying to stay 6 feet. If the meetings could be done outdoors, that would be great. Being able to have those key messages and monitoring on both sides, the refugee side as well as the caseworker for signs and symptoms. Those are our key prevention messages. I think that we're working on some of that guidance in this initial question, but I wanted to give you kind of a little bit of the overview of all the ways now that in this time of the response, we're trying to respond to those identified gaps. Hopefully we will get that consolidation of CDC's guidance to you soon as you start to think about, what the next few months look like for you all. Kim, do you want to add anything?
Yeah, just to echo on what you were saying, and also what someone in the chat box just put through, there's study after study that's coming out that's showing that, even the cloth face coverings are really doing a lot to prevent transmission and to prevent, spraying of airborne particles. But that, so that really is, the first step to that, along with 6 feet and washing hands when you are interacting with people and, and going outdoors. And that's something that I was joking with my other CDC colleagues is that, here in Atlanta, when we see people, I've never seen anyone indoors in, 5 months. Anytime I've seen anyone, it's been outdoors and at a distance. And there's ways to do it safely, and there's ways to continue to have that human interaction, especially with people that have just arrived, but to do it in a safe manner. And also I am just sent through a link to some of our communication resources for travelers that has been translated into a few different languages. And I know that you were talking about the care booklet that is going to be coming out. But in the meantime, there is a temperature log that has been translated in a few different languages that is available now, and a few other resources that are available on the website.
Yeah, I'll just add as well, as we continue to fill gaps and CDC, IOM, PRM, ORR, and CORE continue to have meetings to talk about these gaps. On the CDC side, we also are welcoming feedback, and if there are things that you feel like are really missing, if we are able to cover those or if we are able to address those, we would like to. So I'll put our inbox into the chat box that you can always ask questions to. But hopefully, with what we're putting together, both for the refugees as well as the resettlement agency workers, that we'll be able to give you guidance on what you need in each of these interactions.
Excellent. Thank you for that. I'm going to skip ahead just a little bit because I think we have time really for only one more major question, but I also wanted to note that in the Q&A box, we're getting a few questions looking for resources and supporting resources in some additional areas, specifically taking temperatures or caring for oneself after recovering from COVID-19. So if there are panelists that have any resources that they could share links in the chat box, or if there's anything they know of that's coming up, you can address that through the chat box now. But I did want to make sure that we address this other very important question, and that is around best practices when we have clients who need our support, who have tested positive for COVID-19. What's the best way to safely support clients that have tested positive? Maybe we can start with Michael on that one.
Sure, that's a really good question. It's going to be a big challenge going forward. So kind of what Emily hit on earlier, knowing what you're dealing with. So someone who's been told to isolate, that means that they have tested positive and are believed to still be contagious. Someone who's been told to quarantine means they've been exposed, they've been believed to have been exposed and may become contagious. Unfortunately, with this disease, you can be contagious up to 2 days before you show symptoms. Some people will never show symptoms and may still be contagious. So you have to really approach this carefully and kind of plan around that. So if you do know that a client has been told to isolate or quarantine, finding ways to help them virtually as much as you possibly can, using phone resources, dealing with it that way, so you're dealing with the distance. The other thing is, for those things that simply can't be done remotely, one way to approach it, and I think I saw someone post it in the comments, doing kind of porch visits where maybe you do visit them in their home, but you still keep that distance by staying outside, speaking to them through a window, through a closed door, so that you can deal with whatever you need to deal with. If you're bringing them supplies, whatever, what you're doing, just making sure that you're still maintaining that distance. Taking that approach is one way that you can kind of safely do it. So planning not only to do that, but knowing that this is something that you may need to do, having it in your process that you're kind of able to respond to people this way. And knowing that this may be an issue going forward. Some of those clients who have been pretty self-reliant in the past may now need to isolate, quarantine, may not be able to leave their house, and will need additional assistance now. So kind of planning ahead for that eventuality that there may be more clients with greater need that you need to kind of address through this manner. So always kind of planning ahead is the important thing.
As you mentioned, clients with greater need, just in general, are there any safety guidelines that should be considered for refugee clients who are maybe elderly or otherwise particularly vulnerable? Any words on the best way to handle interactions with those clients?
So, you know, it's funny, it's the same thing over and over again. We always kind of say it's the same guidelines, it's just more important. So, you know, knowing to maintain, keeping that appropriate distance at 6 feet of distance or more, masking up if you're going to be around one of those clients, to the best of your ability, making sure that you do the good hand hygiene, and just being very careful, very deliberate about following all the appropriate practices if you are dealing with a client who has, who might be in one of those high-risk categories and needs special accommodations.
One thing I would add is reiterating the message to families as well that do have older adults or those at increased risk, is that the family unit is the family unit. And one of the things we tried to impart early on with our multi-generational and close quarter guidance was to talk about, if you do have family members, this is more for the family unit rather than the resettlement agency, but reiterating the message that if you do have family members that are at increased risk, either due to age or other health conditions, that you have to think of the family unit as everybody in that family unit then is at an increased risk. So, you know, it doesn't mean that, you know, the kids can run off and meet everybody at the playground and then come home, where grandma might be in a position where she's a little bit more at increased risk. So it's about trying to get those messages across too, that we need to think of the family as a family unit, and trying to take precautions therein. I've also included the resource to the, oh, I realized, sorry, I made a mistake and was sending it to the panelists, but thank you to those that shared that. But the resource for older adults, that link now is in the chat box.
Great, thank you. Unfortunately, we're almost out of time, so I want to start wrapping up. Before closing, I wanted to remind everyone that there are a number of useful related resources that may be helpful as you continue to plan your reopening strategies. There are a few listed here. There's many more on the Switchboard website. Please look through that chat box before we close off for a lot of links that were shared today. And also note that that email that comes to all the participants, hopefully tomorrow, with the recording will also include a comprehensive list of links there. I also wanted to mention that Switchboard is hosting another public webinar in just 2 days, helping clients navigate times of economic hardship. That takes place this Thursday. Registration is still open. We will add the registration link in the chat box now for anyone interested. And lastly, wanted to encourage everyone to email us at switchboard@rescue.org with any remaining questions that we couldn't get to. We'll be really happy to assist and connect you with the right expertise. You can also reach us through a contact form on our website if you don't remember the email address. Before signing off, if I could please, I hope that you would take a very short moment to complete our feedback survey. It literally takes under 1 minute. It's incredibly helpful to us in improving trainings moving forward. That link will be dropped in the chat box as well. But depending on how you joined, your browser may already have that survey open for you as we finish. I do hope you'll stay in touch with us and join us for future trainings. Thanks again for joining today, and a huge thanks to today's panelists, Emily, Michael, Sarah, Tracy, and Kimberly. Really appreciate you all. Everyone take care, and we hope to see you soon. Thank you.
Thank you.